My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. Welcome to this episode of Operate with Zen. I have the great pleasure of being joined by good friend and former colleague, hopefully still colleague, Dr. Andrew Gabrielson. Andrew, introduce yourself to the audience.
Thanks so much for having me on the podcast. My name is Andrew Gabrielson. I'm a PGY4 urology resident at your alma mater, Johns Hopkins. I'm pursuing a fellowship in pediatric urology and will be applying this fall. And my academic interests, I guess, are outside of pediatric urology is work-related pain. Really, surgical ergonomics is kind of a whole specialty. And, I currently serve on the board of directors as well as co-chair the IT and communications committee for the Society of Surgical Ergonomics, which is a new society that just popped up in the last 2 years that's devoted to this topic. So I'm excited to talk about it.
Yeah, so that's the theme for today is, part of our kind of physical health and physical well-being, which is a huge part of being a surgeon, right? I mean, we think about our careers and our academic or non-academic interests and our clinical practice and how we take care of patients, but taking care of ourselves physically is a huge part of having a long and sustainable and healthy and well surgical career.
Couldn't agree more. And, I think that, one of the things that, at least if we're going to discuss career sustainability, is really kind of like defining what ergonomics is. I think it's this nebulous kind of catch-all term, and really it involves broadly the study of the working environment and how to optimize performance and minimize risk to the user. And so that kind of just sounds sleek, but what does that kind of mean within surgery? And we can certainly jump right into that and kind of talk about how that relates to sustainability, but it's definitely more complex than just kind of the postures and things like that we typically think of when we hear the word ergonomics.
Yeah, let's get into the weeds, but I think it's just I think it's important to say we're losing a lot of surgeons early in their careers because of physical issues, and it's kind of one of my sticking points and one of my interests in starting this whole podcast and this whole path down wellness is we're expected to have these 30-year careers, yet we are giving very little training and preparation for how to take care of ourselves emotionally, psychologically, and really important physically. So this is a really important conversation, Andrew, and I appreciate that we're having it today.
Yeah, I mean, I think that Stanford, I believe it was Stanford that actually recently published a paper, it was probably a few years ago, about how it costs about $250,000 to replace a physician. So this is just any physician across the board. And they really didn't leave an upper end in terms of how much more expensive it would be to retrain and replace a surgeon, because obviously the training is longer, but there's also this kind of not tangible experience that surgeons have that it's not like you can just take one surgeon and replace it with another. They're not nearly as interchangeable with skill set and background and things like that. So it's quite expensive. And so, I think money is ultimately a driver of a lot of policy changes in medicine. And, unfortunately, we're starting to see the negative impacts of ignoring this problem for a long period of time.
Yeah, and I'll tell you, sitting in some of the administrative meetings, I think the price tag is for a surgeon now somewhere between $500,000 and $1 million, considering revenue lost if a career ends early and the recruitment of another person as that practice ramps up. So you're talking big profit potentially lost or gained by an institution if they lose surgeons, and potentially gained by keeping people around. It's almost like a compound interest phenomenon. And while we should all be taking care of ourselves, our physical health for ourselves, this is how we get that message across, unfortunately, to the people who are paying the bills and in charge of some of that, and who can support our practices.
Absolutely.
So tell us, so you're right. The common conception about ergonomics is this is how I hold my back and my neck and my shoulders when I'm doing an operation. But let's get into it. Take us from the beginning. When you think about ergonomics, where does it start?
Sure. So I think there's kind of three main tranches of ergonomics. There's physical ergonomics, which I think is what we typically think of. So working postures, device design, the workplace layout and safety, and then as kind of a consequence of that, work-related musculoskeletal disorders. And that's the number one cause of disability insurance claims among surgeons. It's also one of the top reasons that surgeons retire prematurely. So that's kind of the main kind of type of ergonomics that we think about. But there's two others that I think are definitely worth mentioning. Cognitive ergonomics. This is really talking about the mental burdens of operating. And so we can all think about, the burden of quick decision making, periods of stress. One of my colleagues within the Society of Surgical Ergonomics talks a lot about flow disruptions in the OR. And that's a topic that, think about anytime we don't have the right equipment in the room, a patient is potentially not doing well, but we have the situation under control, but there's this mental burden, this cumulative burden that is that we're experiencing throughout the day, and it may not reset when we go to sleep at night. So I think that that's an important thing. The other thing is organizational ergonomics, and this is more of kind of the systems based. This is talking about things like team chemistry, communication between surgeons and, say, the anesthesiologist, the scrub techs, the bedside assistant. Another thing is team consistency. So this is kind of a shameless plug for another one of our members of this society who recently published a JAMA Surgery paper that showed how surgeon and anesthesiologist dyads, people who work together more often, had better patient outcomes. And so, I think that this extends beyond just the surgeon and the people around them. This does translate to kind of better patient care. So I think that those are kind of the three things: physical, cognitive, organizational. And I think that it's key to kind of think about all of them when you're thinking about ergonomics.
That's awesome. And I'm glad you brought up that JAMA surgery paper. We can get into it more when we get into kind of organizational stuff. But one of my favorite parts of that paper is it doesn't take a long time for that dyad to start working. I mean, you're seeing that effect within 10 cases. It's not this massive learning curve that people need to learn each other. These are intelligent people who are highly skilled at what they do, and you put them in the same room 10 times and outcomes get better quickly.
And we can anecdotally just think about how smoothly cases would go when we have the experienced scrub tech, circulators, the APPs that we've worked with for many years. I mean, some of them are driving the case for us. And I think that especially when you inject trainees into that equation, when everything else is kind of on autopilot in a sense, it allows for there to be mentorship and things like that without really disrupting the flow of the case. So I think that that's really key.
Yeah. Well, Andrew, tell us, so physical, cognitive, organizational, is there, between the three, are there common themes that we work on, or does each of these need to be kind of tackled individually?
I definitely think that there's definitely similarities between the three, and there's a lot of overlap. You can't really talk about one without talking about the others. In terms of kind of common threads, I think that there are elements that do kind of span all of them. One thing that I can think of is really the interaction between humans and the tools that they use. So, whether it's the instrument that we're using, whether it fits our hand, and we're able to utilize it well, that could be thought of as kind of a physical ergonomics kind of aspect of things. How well a tool, we can talk about something like the robot, responds to our inputs. And, people think of as robotic surgery as being slightly less taxing than, say, open surgery. But I think you're really just replacing certain stressors on, say, your back and your cervical spine with, your eye strain and neck and kind of hand and finger strain with, having to kind of, you no longer have that haptic feedback and things that you have when you are, doing something open, when you're doing something robotically. I think with organizational ergonomics, I think it's a matter of having the same equipment and having kind of the same group that know how to run, the OR during your cases. So I do think that I think of kind of devices spanning all three of those elements more than almost anything else.
Very cool. So take us through, let's start with physical. Take us through kind of basics. When you walk into the operating room now, you've been, and we'll get more into this later, but I just want to tell everybody, I mean, I remember from your interviews, I mean, this is something that's been on your mind for years and years and years. So when you walk into the operating room now, what's your ergonomic brain thinking? What are you looking at, and how do we make our brains think that way?
So I think the first thing, and people who have, I guess, operated with me recently, we definitely talk about this frequently, is think about what type of procedure we're doing. I mean, all the recommendations that are out there, there are some guidelines for kind of the ergonomic setup for various cases, and they're all procedure specific. So, if we're going in, it's an endoscopic case or a transurethral case. The main things that we're thinking about is monitor position. And that's something that as soon as you walk in the room, the patient may not even be in the room. You can move the monitor, you can move the trolley or the ceiling mounted monitor into a position where it's going to ultimately want to end up. And that may save some time later when you're all scrubbed and you realize that the monitor that you're trying to move is totally out of reach. And now there's a patient that's tubed in front of you and you're having to ask multiple people to get on step stools to try and move it into a place that you can see. So I think that monitor position is just a really quick and easy thing to think about. In terms of kind of where to put it, should be about 2 to 4 feet away from you, should be at the level of the viewer. So about 15 degrees below the horizontal, or roughly at the horizontal of eye level. And people talk about this gaze down vision, where you're kind of almost very slightly looking downward when you're viewing a monitor. And the reason that there's benefit there is that people have shown with EMG studies and things like that, that the eye musculature, if you don't wear glasses, as well as the shoulder musculature, is in its most relaxed state when you're viewing something at like a slightly gaze down view. So that's kind of the first thing, monitor position. The next thing is table height. I think that this is, if we're going to stick with the theme of endoscopic cases, it's really with respect to your target entry point. So if you're doing a transurethral case, it's going to be the urethral meatus is where you're going to be thinking about, where you should be setting the table height. And that height should be roughly between the surgeon's pubic symphysis and the umbilicus. So somewhere in that range is going to be where most people are going to have kind of the optimal, kind of most neutral body position. If you're doing a perc case, it's going to be at the tip of that sheath. So if you're doing a percutaneous, you're doing a PCNL, that's kind of, you have to think about, the height with respect to that entry point. And the same can be said about open surgery. So, if you're doing an open case, your target anatomy is going to be potentially really deep in the pelvis, and that's where you're really going to be working. And so simply thinking about the table height at the patient's abdominal level may not necessarily be kind of the most appropriate height. And for conventional lap, it's really that tip of the port with pneumoperitoneum. So, again, these are all things you can think about, kind of what that entry point is and kind of where that is with respect to the surgeon's body. But those are the first two things I think of.
Yeah, I love this, Andrew. And I'll tell you, I mean, we all know when it feels right in the operating room, but we don't often have the words or the objective description to do that. And I think what we're talking about today really makes this easy. And just kind of hearing you and processing it myself, the first thing I think about is view, right? That's the first thing, is where are you looking? And you gave a lot of great kind of endoscopic or laparoscopic stuff. And open, I mean, the first thing we always did traditionally too is make sure your bed's underneath the lighting, make sure your lighting triangulates, right? It's all about view. So the first thing is view. And then I love this table height, site of entry, like where are you going in? Mm-hmm. And get your pubic symphysis or your belly button kind of in that level. I think that makes a ton of sense. And being in a training program, just tell us, I know the answer to this. I think I know the answer to this, but people are different heights, people are different sizes and shapes. How do we work together, doing this?
Yeah, so there's actually a great picture that I think Ian Soriano, who's a general surgeon at UCSF, has posted, I think, at least once, that shows like equality versus equity with a table height in the OR. And it shows, you know, the tallest surgeon, you know, if everyone has the same kind of step stool, the tallest surgeon is going to be hunching all the way down. The shorter surgeon may actually be at an appropriate height. Table height should be set such that it is most appropriate for the tallest surgeon. And so for the tallest surgeon to be able to rest their arms flat on the patient's abdomen, if it's an open case, and really it should be shorter surgeons that are using a step. I think step stools have gotten a lot better. They used to be very narrow, and now they're a lot more broad-based and a little bit more stable. But of course, surgical culture, typically the height of the table is going to be set where it's optimum for the attending surgeon, kind of irrespective of their heights. So I do think that that's something that is a kind of a cultural change for it to be the optimal height for everyone involved. But certainly setting it to the tallest surgeon is definitely the preferred method.
And so next up, I would think about, and tell me if I'm thinking correct or wrong, is now our body. How are we holding our body? And what are the practical or clinical tips you have for us as surgeons, how we should be holding ourselves?
Certainly. So when thinking about postures, I mean, we can stick with open surgery. You know, there's a tendency for us to kind of lean forward. And some of that may be because of what you have mentioned, which is just visualization of the target anatomy. So I do think that having your lights placed appropriately, thinking about the loops that you use, I think is also key. The declination angle of your loop, so that's kind of the angle between kind of the horizontal viewing angle and then where your loops are looking down, is going to play a big role about how far hunched over you're going to be during your case. So, you know, some kind of general rules of thumb is if you're going to be operating deep in the pelvis, you know, you should be thinking about kind of where your target anatomy needs to be so that your viewing angle is very similar to that of the declination angle of your loops. And I know that that sounds kind of complex, but again, this is one of those things that once you are wearing loops and are setting the height of the table, it becomes pretty intuitive, you know, once the anatomy is in a certain position where you're not leaning forward, and you're able to kind of access what you need to. You know, another general rule of thumb is that your neck angle, the neck angle between the vertical and kind of your farthest forward, shouldn't really go beyond 15 degrees. So if you're feeling like you are really hunched over to access the area of interest, it's probably a table height issue. If you are consistently having to hunch forward, and regardless of the table height, it's probably a loops issue if you are using loops.
Really good tips. I'd love to use this time as a little bit of an opportunity to plug yoga. And I think one of the things that yoga really taught me and helped me in the operating room, in yoga, you use a lot of terminology like front body, back body, side body, depending on where you're contracting and squeezing and holding. And I noticed in the operating room a lot, we all tend to kind of hold upright with our back body, like with our spine and our back muscles. Whereas if you engage your core and your front body, you can actually take a ton of stress off your back and your neck and feel a lot better at the end of the day. So I think body awareness and understanding how you feel and fit in the OR is a huge part of this.
Definitely. And I'm glad that you brought up yoga, because that is definitely one of the forms of exercise that has been basically across the board shown to improve pain metrics and among surgeons, as well as you know, addressing kind of the cognitive ergonomics issue. You know, I feel like, at least personally, you know, if I'm doing yoga, I can't help but be completely present and thinking about breathing, and especially once it's later on in the session and I'm really working hard and just trying to keep up, you really do become mindful of your body positioning, and you really are able to focus on just where you are in the moment. And I think that pays dividends for helping your physical ergonomics as well as your cognitive kind of workload that you've built up over the day or week.
Yeah, I couldn't agree with you more. Let's talk loops a minute. I recently, one of my colleagues, vascular surgeon, has these really cool kind of 70-degree loops, which are it's really weird to operate with her because her head is straight at me and it looks like she's looking directly at you, but she's actually in the field with her eyes. And she said it took a little while to get used to, but her neck and back feel tons better. Have you seen these? Any experience with them?
Yeah, there's I think at least two brands that do these kind of ergonomic style loops with the look down kind of mirrored lenses. And it's interesting because that concept seems so obvious. You know, we're going to be looking straight down. Your neck wants to be not bent over, so might as well do the work with just designing the lens. So I think that that's something that I have seen. I have worn them. They are very. It does take some getting used to. I guess as a personal kind of tangent, I was a swimmer, and there's actually a style of goggles where it has a similar mirrored lens that forces you to keep your head fully straight up. The only way that you can look forward is to have your head basically facing completely up so that you would otherwise not be able to look forward. And the reason for that is that that's actually the optimal swimming position. It's also going to reduce your risk of pain. But that concept is very kind of, it makes perfect sense. So it's the issue, I will say, with some of those lenses though, is that it's very helpful for people who are doing kind of superficial surgery or doing something where they are, you know, working with their hands down in a space that is not kind of right in front of them. So for instance, if you're doing open perineal surgery, if you're you know, a reconstructive urologist or an OBGYN, and your target anatomy is right in front of you, sitting on a stool, you're going to have to be looking up and kind of hyperextending your neck to be able to look at your anatomy. And I definitely have seen firsthand some surgeons who have tried to use old loops that were not kind of optimized for perineal work, and were miserable after just a few cases. So I think some of it is using loops with declination angles that are appropriate to the types of surgery you do. Now, as a resident, you can't win because you're going to do a little of everything. So you have to kind of just struggle with your, you know, your standard factory issue loops.
Yeah, and I always wonder if this is an area where technology is going to help us. Now that we're so used to looking into screens and lens and kind of digital headsets now, that if there's not a time where we can get almost like a drop-in, you know, kind of probe that's sterile and connects to a headset where you could drop it in the field and see with magnification that you would use your loops for, you know, without your head could be in any position you want it to be in. And so if somebody's smart out there who's a biomedical engineer is listening, maybe they'll be inspired and work on this.
I do know that there is a surgical microscope. I don't know if it's been adapted to just have kind of standard vision, but there's a surgical microscope. I believe it's called the Orb Eye. I think Olympus makes it actually, but it's it's a microscope that has goggles that you wear, and you basically can see through it, and you can be looking anywhere in the room, and it's going to be looking under magnification at the surgical area. So that's something that I believe the group out of Miami has done some ergonomics related research comparing that to this typical microscope, and it did have some benefit. Now, of course, it probably has a handsome price tag, but that is certainly something that I imagine will continue to gain traction.
Very cool. And before we leave physical and get into some of the other forms of ergonomics you talked about, what about recovery? What should we be doing at the end of cases, at the end of the day? How do we keep our physical ergonomics healthy?
Yeah, so I think that there's, you know, kind of the preemptive, kind of proactive, you know, addressing issues related to kind of work-related pain and musculoskeletal stress, and you know, then obviously kind of the reactive side of things. I would say that the first thing during the day, if you can, stretch. You know, there's a lot of different stretching routines. The Mayo Clinic has a wonderful website that is devoted to both intraoperative stretching as well as between case stretching that helps kind of target some of those muscle groups that you're going to be working out kind of throughout your cases. There's videos, there's kind of basic kind of, there's a free app actually that helps walk you through it if you wanted to do intraoperative stretches. And it's basically a timer where you can leave it on in the OR and either one of the circulators is running it, or So you can even have it scrubbed in with you, if you want, and it takes you through some of these very basic stretches every 45 minutes or so. And, although there's some cases where you really can't, take that 30 seconds to stretch, but I would anticipate that almost every case we have ever done, there's been some natural kind of pause in the case, whether it's we're waiting for a suture, we're waiting for a monitor that's not working, where you can easily just incorporate a quick stretch. And that's been looked at. There's some good multi-center data showing that improves, mental performance and wellness, as well as it doesn't really increase operative time because there's always a period to take a quick break. So that's part of, the, kind of proactively stretching out those muscles. But, that's not possible for everyone. So I do think that this is something that at the end of the day, going through some of those targeted stretching routines probably takes 10-15 minutes to do those stretches will probably pay a lot of dividends. Hasn't been studied formally, and I think it'll be hard to kind of account for how heterogeneous the types of surgeries people perform and kind of their underlying health issues, but it's something that's been kind of universally well received. So stretching, I think, would be the main thing.
Excellent.
Or yoga.
And Andrew, I'd like to just thank you for telling us where there is research and data and where there isn't. And I will make sure I put the papers and the websites and the apps in the notes of this podcast so people who are interested can find them. So I really appreciate you sharing the data where there is and letting us know where there are holes as well. One other question popped up in my mind as we were talking about this. What are there other technologies we can use to help us with physical ergonomics in the operating room? I know you have some interest in this, but tell us kind of where we are on that front. Is it just sensors? Are there other things that we can use or that are coming down the pipeline?
Yeah. So there are some wearables. There's some wearables that are very straightforward, some that are a lot more sophisticated, that have inertial measurement units and are kind of giving you feedback as to where your limbs are in space. There's some very basic ones that basically have the same kind of measurement unit that's in your iPhone that knows whether it's kind of upright or it's sideways. And some of the basic ones I've played around with. One of them is called Upright Go. It's a small, probably the size of a quarter, that can sit on your upper back, and it basically tells you in a binary way if you're slouching or not. That's something that I've worn to the OR. And you can have it in a training mode where it gives you a light little buzz when you're slouching for too long, or you can just have it in a kind of a educational mode for yourself, where it doesn't buzz you. You can kind of see, wow, I slouch 60% of the day, and so that's one thing that I've kind of played around with, and it definitely makes me more mindful to be kind of upright. Gel mats, kind of the foot pads that have these kind of anti-fatigue mats have been looked at as well. That's actually something that I think has been looked at in randomized trials, and that has been shown to reduce kind of lower extremity discomfort, lower back pain as well. So I would say that those are two things that have I've personally used and have had some success with. One of them with more data than the other. In terms of other kind of ergonomic kind of tools, I think the devices that we choose to use have a big impact on kind of the stress that we experience. One thing that pops into mind is our scopes. Digital scopes are significantly lighter and easier to handle than some of those kind of older fiber optic scopes with a removable lens piece. So, if you're able to, get some of those newer, shiny new toys, some of the benefits that they probably don't advertise with those is that they are significantly lighter. And so if you're doing, 8 ureteroscopies in a day, having something that is significantly less painful to use is certainly something to consider. Those are some of the main things that I can think of. But there are other things out there. That Orbi thing that we discussed, where you're not having to kind of crouch to put your face into a microscope. You can have wearable goggles that is giving you a crystal clear image, and you can be looking over the side, grabbing something off the Mayo tray with perfect vision the whole time.
Very cool. I'm going to use the opportunity to plug gel mats too. I recently tore my ACL and I had surgery, and I never thought about gel mats. I kind of thought they were overrated. And then the nurses, when I was doing open cases, would just brought them in for me, and I started standing on it because my knee and my leg would hurt. And I will tell you, at the end of the day, not only did my knee feel better, everything felt better. So now, anytime I'm doing an open case, I'm like, "Hey, where's that gel mat?" They are phenomenal, and I'd love to see them on both sides of the bed so that our residents and trainees have them as well. And the other thing I'm going to ask you, Andrew, that comes up all the time in questions and discussion groups: shoes. What shoes should we be wearing? I'm sure you're going to say it's personal, but tell us what we know about footwear in the operating room.
Yeah, I mean, I'll start. It's personal. The first thing I would say, something with good arch support. I think if you're going to be looking at, some people swear by the Dansko shoes. Some people wear just kind of standard athletic shoes. I personally have worn Crocs for every single day of residency, and my Crocs they're closed-toed and they are very robust and they have good arch support and they have worked for me. I think one of the things that people don't think about with shoes is actually the width of the shoes. So obviously there are some that are kind of quite narrow, and obviously some of this is going to depend on your foot type. But when you're engaging certain devices with your feet, so I'm thinking kind of the more endoscopic cases, there have been some studies that have looked at kind of the width of shoes, the outer width of shoes, and given preference to some of the ones that are a little bit narrower in terms of being able to kind of activate certain pedals, whether it's fluoro or kind of surgical energy, things like that, bipolar. So in terms of comfort, I do think that's going to be a kind of surgeon specific kind of thing, but I swear by my Crocs. They are like $10 and they are wonderful.
It's funny how we all find that, it was very trendy to wear Danskos when I was a resident, and I feel like that comes in and out. After years, I realized I hated them. They did not work well for my feet. And I joke, Nikes were made for Michael Jordan and me. They just fit my feet really well. And Nike makes a pair of medical shoes, which fit me perfectly. And so anytime I find them, they're really hard to find. But anytime I find them, I buy a pair or two because they work really well for me. So yeah, I think it is highly personal, but you got to experiment and to kind of the mindful approach, be intentional about what you're doing. Find what works for you. Think about what you're wearing and don't just buy what looks cool or what you like. Find stuff that actually makes your day better and your week better and is going to help you sustain a career.
Absolutely. I would also add that if you do wear tennis shoes or something where you can have an insole, it's worth the money to go get a custom insole. I mean, I go running a fair amount, and I would just wear kind of whatever shoes that I found at some sort of basic running store. Didn't really put a lot of effort or time into thinking about what good shoes were, and then this one store said you should probably try custom soles, since it seems like the shoes that work for you are a little bit not the standard shoe that we typically would like recommend everyone. You probably just have a certain configuration to where you put weight and things like that. You're going to benefit from this, and it has been life-changing. It's been amazing. Significantly less pain with running. I feel like my knees don't take a hit as much. So if you do wear shoes like that in the hospital that have an insole, custom insoles are not terribly expensive. I think $50-$60 at least where I've gone. So it's worth it.
Very cool. Well, Andrew, take us through cognitive and organizational ergonomics now. What do we need to know and what should we be thinking about here?
So I guess we can start with kind of cognitive. This, I think, is a little bit more of a kind of a nebulous space. I will plug, there's a great paper kind of about surgical stress effects from Kristen Krauser from Michigan. Definitely worth a read. And it talks about kind of really like the different surgical stress effects that can happen in the OR and how this can be this cascade of, one thing kind of goes off a little bit, the standard protocol, and then, it kind of compiles over the course of the case. And so in terms of, how we can create systems that kind of benefit the surgeon, I like to kind of think back to this whole, the concept of ergonomics is really adapting the environment to fit the surgeon and not vice versa. And so, in terms of like what I think about when thinking about cognitive ergonomics, if I walk into the room and I notice that there's, you know, a brand new team, we don't have a lot of the equipment that we need in the room, you know, one thing that you get to do as a resident is you get to come in and kind of take an appraisal of everything and say, we should grab all of these things. These are all the things that we need. And some of that's a good educational exercise for us to make sure we know what is needed for the case. But ultimately, I think that brings the stress levels down significantly for the case once it's actually going. You know, you have everything you need. And potentially if it's people who haven't worked with you before and maybe haven't done that case before, talking about things to kind of expect and things like that. And it's really kind of building a building up a, I'm trying to think of what the term would be.
Well, I'll throw out some mindfulness terms for you. I mean, just listening to you kind of talk about this, where reducing anxieties, increasing comfort levels, increasing discretional energy in the room, because people can spend their mind power and other things on the patient and the surgery and the other things instead of worrying about what equipment they need, or is the surgeon going to be upset, or, you know, those kinds of things. So yeah, I hear exactly what you're saying. And I think taking appraisal to allow you to be present in the room is, I think, really powerful here.
Completely. And then in terms of organizational ergonomics, this I think is also something that you can think about not during the case, but before cases and reflection on previous cases. So there's certain things you can control. There's certain things that you as the surgeon can change, your own posture, the tools that you're maybe choosing to use. Those are things that you can kind of deal with within yourself, but there are also kind of organizational factors, systems factors that you may have to reach out to other people to kind of make work for you. And so I can give the example of, if you come into your OR and every single time, you know, the monitors are in a position that are hard to access. There's, you have, the table that you use hasn't been working in terms of being able to change the, table height, things like that particularly well, or it doesn't have that gantry that allows you to kind of roll the table down for certain fluoro cases. Some of these things are just having that on your case card and being kind of firm. This is something that we absolutely need. And I think that surgeons, the surgical culture, is we kind of also have been used to kind of being very flexible and kind of being willing to kind of utilize maybe less than the ideal situation. And some of that's important to be dynamic and to be able to work in different conditions, but there are also certain things that you can control. And I think that being proactive to make sure that the system is kind of as optimized as possible, I think everyone ends up winning in that circumstance. So, I think that that's something that can help.
Yeah, for those following on YouTube or seeing the video, you're probably seeing me smirk, and Andrew's probably thinking the same thing I am. There's a very, very, very prominent surgeon that we both worked with extensively who was famous for saying MD stands for make do. And we often do that in the operating room and in our existences. And we don't always have to, right? With a little bit of preparation and systems-based approach, I love what you're saying here. We don't have to make do. We can make the do happen kind of before we get to the operating room. So it makes a ton of sense.
Yeah. And one thing that, I remember when we did that survey, really looking at residents, urology residents, as well as faculty, and kind of asking them, what are things that you would be willing to kind of incorporate into your day? One of the things that came up was incorporating an ergonomics kind of check into the traditional surgical timeout. And, I think we do the timeout. The goal of it is to ensure safety of the patient, that we're doing the right case, we have the right patient, we have the equipment that we need, any safety concerns. And then we also touch on a safety concern that's for everyone in the OR. We always look for, where is the fire extinguisher? But when it comes to the safety and kind of well-being of the team, that's kind of overlooked. And I feel like that's a perfect kind of moment to take an extra 30 seconds to say, okay, quickly, where are our monitors positioned? Okay, they are way off in the corner. Do we have all of the, equipment that we need? Great. Is the table height up correctly? Perfect. Let's move on. It doesn't take that much longer. And that's a naturally arising kind of pause in the day. to kind of reflect on some of these things.
Yeah, I think that's huge. After Chris Krauser was on the podcast, about a year ago or so, and after talking with her, we've kind of incorporated ergonomics into our timeout. It once you get used to it, it gets really brief. And from her, I learned, when I come in the morning, not only do I check and make sure we have the right equipment and those issues, but I walk around the room, make sure the monitors are where they're supposed to be, lights are where they're supposed to be. And then quickly after we do kind of our patient ID timeout and, we set our intention, then I allow, hey, do we have the monitors? My PAs are amazing. Kaylin, Michelle, are the monitors where you need to see? Can you see? How are we doing with the room set up? And it takes 30 seconds and it makes a huge difference in the day. And it also tells everybody in the room that ergonomics is important and those people are important to us. So we need to make sure we take good care of them.
Well, I have no doubt that you are, setting a great example also for, just kind of the group. Because I do think that's another thing that it kind of comes from the top in terms of, destigmatizing and normalizing these discussions about these things. I think that historically it was, to complain of pain or to have, any issue with the setup would be, considered a sign of weakness. Or a lack of kind of determination to get through this case, and I think that that's silly. I think that we're growing, there's a growing acknowledgement that that is silly, and that, but it does come from the top. So that's important.
Yeah, absolutely. I love what I do. You love what you do. We want to do it for a long time, right? We didn't go through all this training and practice to burn out either mentally, physically, or however. And so by taking 30 seconds to make sure that your back and your elbows are good and your neck's not going to hurt at the end of the day makes a huge difference at the end of the day and at the end of the week, and hopefully over the course of a long career.
Absolutely.
So Andrew, we've covered a lot here. I want to get into you. So as long as I've known you, you've been interested in this. Tell us this story. Why did ergonomics resonate with you, and why is this your future career?
So I guess the story starts with personal injury. I tore my labrum. I didn't know at the time, but tore my labrum, dislocated my shoulder playing water polo. This was probably end of undergrad, and I kind of nursed this injury for several years. Part of which was because there really didn't feel like there was a convenient time in the med school timeline to kind of, be out of order for a period of time. So this was something that I kind of nursed along the way, and it really wasn't until I was becoming clinical and, doing my surgery rotations and my sub-Is with this injury that I realized, wow, holding retraction for a really long period of time, like I can do it with this arm, no problem. This is pretty tough. And it was something that over time I recognized, like, this is something that I have to address if I want to like go in this direction as a career. I ended up getting surgery, and the recovery was long, but I think over time I recognized that this injury really impacted my work and my ability to kind of give my best in a clinical setting. And so over time, I also, started to kind of collect information from, colleagues, from mentors. I saw them experience pain, have to take time off from work, get surgeries. I looked into this topic from a research perspective and saw that there was very little out there. There was a few very prolific people in this space, but other than their work, there was very little out there, and it really wasn't specific to any field, which I think was also surprising. It was kind of general surgical ergonomics. If anything, it was more kind of general surgery focused. So I felt like there was this huge need within urology, within really any specialty where we are doing virtually every type of surgery: open, robotic, kind of endoscopic, microsurgery. And so I felt like there was this huge unmet need, and that would be, it's something that I was interested in and had personal experience with. So I felt like it was an important problem. And over time, it's kind of been nice to see it gain a lot more attention, and people are starting to get more excited about getting involved with it. So yeah, it's been a lot of fun.
Very cool. So just tell us through some of the basic processes. What have you taken on in terms of research? And I know you talked about at least one of your papers, you've got a bunch, but just tell us kind of some of the projects and how they've evolved and where you see this field going.
Yeah. So I think the first thing that I have to, do a shameless plug for is the Society of Surgical Ergonomics is this awesome group. I mean, we're growing, it seems like exponentially, but kind of the core group is this, amazing, diverse group of surgeons, ergonomists, human factors experts, physical therapists, occupational therapists, and they're really all kind of coming together to try and tackle some of these big deficits in ergonomics research. And so when you're kind of, what you're alluding to, kind of where the field is going, I think that this collaboration has been lacking forever. And so what's been fun is to kind of on these research symposium and these various calls, hearing the perspective of people who have thought about ergonomics from a kind of theoretical standpoint, and those who have no theoretical basis and are simply just going out there and kind of doing it. And once they talk together, they realize they're speaking the same language. And so in terms of kind of in the short term, I hope that we're going to be developing and validating guidelines, ergonomic guidelines, and that will ultimately be specific to procedure type, and then also most likely to specialty type, because open surgery in one specialty is not going to be the same as open surgery in another. Education, I think that there's a lot of really good data that no one gets trained on any of these topics. Something like 90% of people have never had any sort of formal surgical ergonomics education in their teaching. And so I know that the SCORE curriculum for general surgery residents has already had a kind of an update, some of which was done by members of our society to create a curriculum to teach residents and faculty basic principles of ergonomics. And I think that this is something that general surgery has done a good job of making a major priority and saying this is something that everyone needs to know. If you're going to go out there and be operating on people, you got to know how to protect yourself. So I think education, I think kind of the programmatic kind of creating buzz, creating collaborations around this. And then I think the last thing is working with industry. And, I think industry is also starting to get excited about interfacing with surgeons to find solutions to ergonomic problems with their devices. There's a great picture that definitely was circulating around Twitter where two members of our society had their hands kind of up against one another, and one wore, I think, a size 5 glove and the other wore like a size 9. And they both are laparoscopic surgeons. They both are people who are doing the same type of surgery, doing this using the same instruments. And most devices are not accounting for differences in the arthropometrics of surgeons. And so I think that ideally we would like to create these rubrics that we can basically take any old or new device that's coming out on the market and describe it from their ergonomic characteristics, kind of like a JD Power and Associates for surgical devices. So my hope is that that's something that's going to become a standard way of kind of vetting new devices that are coming to the market to make sure that everyone can use them. But those are the things that I think I'm most excited about. I could probably talk your ear off with other projects that are going on. Yeah, shameless plug. If you're interested in these topics, I would highly recommend joining the society. We have, it's a great group of people and plenty of opportunities for collaboration.
I love it, Andrew. I think those are really fascinating and interesting. And I think and I don't mean to belittle the work at all, it's relatively low-hanging fruit. I mean, these things are achievable. Guidelines, education, partnering with industry, this kind of rubric to describe ergonomics and the devices and instruments we use. I think this is stuff that's easy to do and be hugely impactful for the field. So I give you great credit and great enthusiasm as you go ahead and kind of work on these. I will have one ask for you. And I think there's one other area that I think about that I think we can work on too. And that is kind of the policy or administrative portions of this too. And I'll go back to your injury. And you said one of the things was there wasn't a convenient time to take off from your medical training. Well, what if your institution made it convenient? And I've thought about this a lot since my knee injury, and I took one between day of injury, surgery, and recovery. I took off 1 week, and that was the week post-op. And to be honest with you, I did fine. I was able to operate. There was no detriment to my care. But it would have been really nice in retrospect if the hospital said, listen, Phil, we know you're going to be here for a long time. We want you to be here for 10, 15, 20 more years. Take a month off. Here's 1,000 RVUs. Don't worry about your budget this year. We're not interested in your budget this year. We're interested in your budget for the next 20 years. And that could be at any level, whether it's medical school training, resident. And I think that's something I think about now in a role in leadership. And I think we all need to think about. Surgeons are going to have injuries. We're going to have physical problems. We are elite performers. I like that word, that terminology a lot. We're not athletes necessarily. We do physical things, but we are elite performers. And the physical nature of this is going to put us in trouble every once in a while. And to have an institution that supports us through that physical recovery, I think is huge for our well-being, huge for recovery, huge for sustainability. So I'll make that push and ask maybe when you guys are planning subcommittees in your future meetings to maybe start some working groups and think about that, because that's going to take a long time to change, I think.
Yeah, no, I think that's a fantastic point. And I think that that's something that we would love to see more of. Unfortunately, the cynical part of me thinks that it's going to have to require losing surgeons, for hospital systems to look and see, wow, this is truly a problem that we have to fix. And my hope is that by bringing greater awareness to this issue, and advocating for ourselves both locally and nationally and internationally, that this is something that hospital groups are going to say, we can't ignore this problem. We have to protect our own. I love the idea of kind of being proactive with the recovery process, and someone reaching out to the surgeon saying, hey, listen, we would prefer that you actually recover and not just work through this and impede your recovery, because then you're going to be jeopardizing the next 10 years. And losing a month will seem kind of, the term, penny wise and pound foolish. So, yeah, I like that a lot.
Yeah, I mean, we see it all the time in professional sports, right? And there's lots of analogies from athletes. And listen, they get hurt, and yeah, you could come back from your ACL injury really quickly, or you could just take some time off and come back and not risk another injury or a worse injury. Just let it heal, come back at, full capacity and work hard, play hard, do all of those things, right? So Andrew, we're getting to the time in the podcast where I turn this around and say, is there anything we didn't cover, anything you want to go over? And I know we could do this for hours and hours and hours. You and I both love talking about this stuff, but is there anything that the audience needs to hear that we haven't covered in the last 45 minutes or so?
I think the one thing that I was also going to bring up is, we talk about all these interventions and different things that we can change within ourselves or our local OR. But one thing that the society is really trying to do is to find these surgeon champions. That's kind of how we describe them. People who are willing to implement some of these interventions, ergonomic interventions within their OR, and trial some of these things to see how we can troubleshoot and kind of better understand what are the implementation barriers to making surgery more safe for the surgeon. So I would love to see people kind of share their experiences with trying to incorporate some of these things, whether that's through social media, whether that's through getting involved with our society. So that's something that I'm hoping that, I would challenge you. It already sounds like you are implementing things within your OR, but if you feel like you have a good setup, you have a good system, you have a good surgical timeout that incorporates ergonomics, to tap others in your institution, within your department, and see if they can implement those same things within their own kind of experience, and hopefully at some point reach out to leadership, get buy-in from the higher ups to try and make these policies widespread. So I mean, I think that that's something that I would love to see other surgeons do, especially those that are at the attending level.
Well, thank you, Andrew. And I don't think you're going to have a hard time finding surgical champions. And hopefully we identify a few who are listening to this podcast and either contact you or the Society for Surgical Ergonomics and get involved with their leadership in the institution to help do that. So I think we can challenge both of ourselves to help kind of grow that growing cadre of people.
That would be amazing. And yes, anyone can reach out at any time.
Yeah. So I'll take the time now just to kind of summarize the things we talked about, the amazing things you said. We actually started, I don't know if you remember, with the Society for Surgical Ergonomics. It's one of the first things we talked about. And I think it's been a thread throughout. So we'll make sure we'll put all of the links in the notes for this. But this is a group of human factor specialists you talked about, and they're doing amazing things, research, collaborative groups. They're working on guidelines, partnering with industry, a number of things to improve how we all work and feel in the operating room. And I think it's important to remember what the definition of ergonomics is, right? This is a study of human efficiency, and surgical ergonomics has to do with our efficiency in the operating room. And you broke it down into 3 components that make a lot of sense. Our physical ergonomics, which I think a lot of us, that's what we all reflexively think about, but also the cognitive and organizational ergonomics that help us work more efficiently and better in the operating room. When we talked about physical ergonomics, we talked about just some basic things. First, adjust or think about your view, whether you're doing the operation open, endoscopically, laparoscopically, whatever it may be. Think about your entry point into the patient, into the anatomy. Set your table height between your pubic symphysis and your belly button. Be thoughtful about your postures and avoid hunching. However you want to get to that through body awareness. We both talked about yoga and use yoga, but we both recognize you don't have to do that. You want your neck angle 15 degrees or less. Stand on a gel pad if you can get one, or ask your operating room to get them for you. And these were just some of the things we talked about with physical ergonomics. And then with cognitive ergonomics and organizational, I think the way I kind of view these things now is kind of the micro and macro scale of planning and preparation, where in the operating room, how are you organizing things for yourself, making things better, versus how can we address them as a system-wide approach to equipment and partnerships and teams, and lowering cognitive dissonance, increasing discretional energy in the operating room. So we're not anxious about what equipment's in there, how things are set up, but we can just focus on the task at hand. We can be more present, focus on the patient, their problem, and the surgery we're about to perform.
You nailed it.
Well, good. Well, Andrew, you were amazing. It's always fun talking with you. It's been really fun spending the last hour with you. And I know people are going to benefit from this conversation. So thank you.
Likewise. Thank you so much for having me, Phil. Great to see you.